Okay, спасибо. Okay, morning. Let's start our lectures. Topic of our lectures is anatomy and physiological particulars of urinary system in children, methods of investigation, and semiotic of disorders of urinary system. Please, you can fix your presented lectures. I hope we have of disciplinary students. Okay, urinary system of children includes some organs of urinary system and renal development and function start from development of urinary system has embryonic development with 3 periods of this development. It includes pronephros, mesonephros, and metanephros. It's information from your previous subjects such as histology. Kidneys start to develop between 3-4 weeks of fetal age from indifferential mesodermal non-specialized tissue. Pronephros, the first kidney named pronephros. Its development in cranial part of embryo. Pronephros is 2 to 5 canals. They open in cavity of body and other ending are connected in common duct, Wolff's canal. Then in cloaca. Pronephros doesn't function. Mesonephrons. After 5-6 weeks of embryonal development is developed primary kidneys with name of mesonephros. Mesonephros is formed from convoluted tubules. The glomerular Bowman's capsule is formed from 3 endings of mesonephros. Canals are connected with mesonephral duct, then are opened in vesical sinus. Mesonephros is functioned 2-3 months, and hemicaudal segment take part in formation of sexual glands. Metanephros. Secondary kidneys, metanephros, start in development on 2 months, 6 weeks, or in caudal part from nephrons. But excretory apparatus is formed from diverticles of mesonephral duct. Nephrons are attached to connective tubules after 20-26 weeks of intrauterine development. In human fetus, urine formation is believed to start between 9 to 12 weeks of gestation, initiating urine formation and contributing of amniotic fluid. In later stage of pregnancy, the amniotic fluid is largely derived from fetal urine. By 15 weeks, minor calyces, renal papilla and renal lobes are present, and by 22 weeks, medulla and cortex are clearly demarcated, and a third of nephrons are formed. Nephros induction cases is about 26 weeks of gestation. The last generation of nephrons are in cortex are immature. They have undeveloped proximal tubules and short handless loops. The full components of nephrons is present by 36 weeks. The full complement of nephrons is present by 36 weeks. The growth of kidneys parallels general somatic growth, but the latent capacity of kidneys to grow continues well into adulthood, just into adulthood. When one kidney is removed, the other kidney hypertrophies by increase in the size of individual nephrons, such as variance compensation of function. Conclusion. The first our chapter of topic. Urinary system form from two mesodermal parts, then these parts connects. Kidneys form in caudal part of embryo, then lifts from pelvic cavity to lumbar region. This is a reason of different anomalies, aplasia, agenesia, and dystopia. Variants of aplasia and agenesia. Aplasia and agenesia. Aplasia is for absolute absence of organs. Agenesia is don't start from organs with from initial part of embryo, and you can see these different variants of aplasia and agenesia on the left part of pictures. You can see aplasia and agenesia, aplasia of left ram, full aplasia without ureter, да? And in the middle present ureter to even bladder, and agenesia of left. And on right you can see and this agenesia of right ran with abnormalities of ureters from left. Ran. Variants of doubling of kidneys and ureters. You can see different variants on these pictures. Doubling of kidneys may be absolute or relatively, or if present two ureters, it's present a full doubling. Variant of kidneys dystopia. Dystopia is term with abnormal position of kidney in abnormal anatomical position of kidney in human body. In normal variants of dystopia, maybe you can see kidneys in chest cavity, kidneys in pelvis, and pelvis in with a low or maybe upper or maybe down variant of abnormal position. Dystopia maybe on this different variant. Next chapter is anatomical morphological particularly of urinary system of children. Kidneys of children are relatively more than adults. 1 to 10 body mass of children's and mass of adults just only 1 to 200, 1 to 250. Ratio between mass, kidneys mass and body mass. Shape of kidneys is spherical, then bean shape. Weight of kidneys is 65 from late, and for adult it's parameters between 30 to 35%. Place of children's kidney is low than adult, level of 1 to 5 lumbar vertebrae. For adult it's more correct to 11 to thoracic to first lumbar vertebrae. Fibrous capsule of newborn is more than and lipid capsule absent. A ligament is undeveloped and renopexy is weak. This reason of nephroptosis, it's a low, it's a position, low position of than normal of kidney. Kidney has physiological lobar structure till to 2-4 years old. If more long, this is pathology, spongiform of kidney. Physiological lobar structure, it's normal for babies up to 2, maximum 4 years old. Balance of cortical and medullary layers of children are 1 to 4. For adults, it's ratio 1 to 2. Balance of cortical and medullary layers. Nephrons is functional and structural unit of kidneys. Glomerule is poorly differentiated, has diameters 85 micromillimeters, and adult glomerular diameters 200 microcentimeters. 200 microcentimeters for adults. Epithelium of glomerule is cylindrical and cubical. At adults, it's squamous epithelium. Canals are smaller. Diameters of children's canal is 2 times less than adults. Handless loops is undeveloped. You can see this picture, a schematic diagram of specific transport defects in some renal tubular disorder. It's present for your better understanding in what place main structure unit of kidney of urinary system that present different disorder, a special tubular disorder. Pelvis is relatively more than adults. The wall is undeveloped, hypotonic because muscular and elastic fiber is not good developed. This is reason of congestion of urine and inflammation. This is a reason of congestion of urine and inflammation. Ureter is longer and wide, convoluted muscular elements and undeveloped. Elastic fiber absent. This is the reason of megaloureter and hydronephrosis. Megaloureters increase in size of ureters, and hydronephrosis. It's also distal part of ureter, intravesical part, is short 0.5 centimeters of newborn and 1.5 centimeters 10-12 years old. This reason of vesico-uretral reflux, one of the most important reason of different disorder of urinary tract, especially in early age also. Urinary bladders space is higher and is palpated by doctor. Muscular and elastic fiber of urine bladder and ureter is undeveloped. It's a reason of reflux too. Reflux at output, not output, re-put urine from vesicle, from urine bladder to ureters. The main function of kidney includes excretory, nitrogen eliminative, concentrative function, erythropoietic function in early age, especially in intrauterine periods of childhood and some weeks after, maybe after birth. Homeostatic function, very important, it's correct pH and electrolytes balance, and endocrinal function. You will study about renin-angiotensin system. The functional particulars of urinary system of children. The first urine usually has a specific gravity about 10-15. During the first week of life, the urine is scanty and quite dilute, probably as a result of poor response of antidiuretic hormone and immaturity of renal tubule. It's for your remember urinary specific gravity of children according to age. In early age of newborn, a specific gravity from 10.06 to 10.12 specific gravity. Pay attention to babies of first years old, 10.02 to 10.06. It's very diluted urine. and from 10 to 5, from 2 to 5 years old, it's between 10:09 to 10:16, and nearly age of 10-12 years old, the specific gravity state to be such as adult. It's nearly 10:12 to 10:25. During the neonatal period, the low clearance of sodium chloride and urea resulting in a hypotonic urine as compared to plasma. The percentage of uric acid is higher than in urine of neonate than late. Glucose and albumin may be normally be present in urine. Glucose and albumin may normally be present in urine just in neonatal period, just only neonatal period. In another periods, it's abnormal. You must remember about it. The main function dates of kidneys condition according to age. Two very important parameters for nitrogen for excretory function of kidneys. It's clearance of endogenic creatinine and maximal tubal resorption glucose milligram minutes. And you can see this parameters for newborn, and you can for baby of first years old, for another childhood, and for adult. You will see very differ, especially for filtration, parameters of filtration of by clearance of endogenic creatinine. Urine volume. His average infant secretes 15 to 50 milliliters of urine per 24 hours during the first 2 days of life. The first 2 days of life during 24 hours. That's a lot at a small volume of secrets of urine. 50 to 300 milliliters per day during next week. 25 to 250 and 400 milliliters per day during the next 2 months, and 400 to 500 milliliters per day by a later half of the first year's life, later half of years. There is a subsequent and gradual increase of urine output. 700 to 1000 milliliters are secreted during age 5, 6, 8 and 8 years old. It's secreted during age during 1 day, 24 hours, every 24 hours, and 700 to 1500 milliliters its secretion of urine between for every day between age of 8 to and 14 years old. Its formula of urine volume calculated after 1 years old. By this formula you can calculate what must be volume of urine on this age when the n is the age of patient in year. It's just after 1 year old. Volume of urinary bladder. It's also very neat information for understanding of anatomy physiological features of newborn of children. For newborn, volume of urinary blood just only 30 milliliters. To during first years old, it's between 35 to 15 milliliters from and increase from after 1 years old. You can see to volume such as adults in 12 to 15 years old. It's between 300 to 400 milliliters. Its volume, its functional volume of urinary bladder. Glomerular filtration rate is low during the first 9 months of life, as are urea clearance, renal plasma flow, and maximal tubular excretory capacity also. Creatine is excreted in large amounts by the infant and to a lesser degree by children to the time of puberty. The male adult excreted almost no creatine, whereas female adults excrete very little. Creatinine output increase throughout the growing period. The quantity being directly related to amount of body musculature. The urination is frequent and involuntary from newborn to 25 times per day. 25 to 25 maximum. Frequency of urination in children of different age. You can see its parameters of this frequency of urination of children in different age. You can see for newborn from newborn to till to 6 months it's 20, 25 maximum. From for second half of first year's life it's 15 to 16. From 1 to 3 years old 10, 12. It's parameters need for estimate neurophysiological development of children, and urination act must be control or start control. From 3 to 7 years old it's 7 to 9 times per day. And another parameter you can see. Method of investigation of kidney. Method of investigation of kidney. The first, its clinical method includes speaking with patient or interview with patient and start from take specific complications. Specific complication according to urinary tract and urinary system is a pain in lumbar region, in abdomen during urination, change color of urine, such as complications, increasing its pollakiuria or decreasing of frequent of urination. Increasing of urination, pollakiuria, it's then it's name of this phenomenon. You must remember. Disorder of transparence. Disorder of transparence. Pain in lumbar function, in lumbar region, pain during urination has a different another characteristics such as localization, irradiation, periodicity, and intensity. Character of urination. Urination maybe includes different name of disorder of urination. Bradyuria, it's low rate of urination. Dysuria, it's disorder with urination and complex urination with pain, for example, and another different things. Enuresis or nicturia, it's when in elder patient we have disorder of urination control during day and during night is nicturia. Strangury, pollakiuria we can see previous slide. Volume, volume, disorder of urination, daily volume per and volume per one urination. Voluntary or involuntary. Voluntary or involuntary, it's also characteristic of urination. Extrarenal complaints includes the thirst, headache, nausea, vomiting, dyspnea maybe, and pain in height region. All of these extrarenal complaints may be correct with renal problem, kidneys problem, such as secondary problem of kidneys disorder. External examination. During examination, we can find different problems with kidneys. Includes during examination of patient, we should see different anomaly of development, different position of body, includes it's depend of present of painful syndrome, change color of skin for kidneys disorder, more correctly a pale color of skin. Edema of face, eyes, lids, extremities, sides. Patient need to by control of body mass. Edema very specific for kidneys disorder symptom. Odor of urine from mouth is a result of renal failure. Abdominal asymmetry, Wilms tumor or hydronephrosis when present these diseases, we can found abdominal asymmetry. Estimate condition of sexual organs, secretion, edema, hyperemia, hydrocephalus, hematocephalus, phimosis, and another. It may be also one of reason of problem with urinary system. Such as here, you can see edema of face, eyelids, extremities, aside patients need control of body mass. You can see facial edema in nephrotic syndrome, very specific situation. Cross edema of scrotum and legs, well, abdominal distension from ascites. Main urinary syndromes. Urinary syndromes is complex of symptoms which presence in urine analysis. In urine analysis in urine, and because urinal syndrome. Hematuria, it's microhematuria or macrohematuria. It's presence of red blood cells in urine. Red blood cells in urine, if we have microhematuria, urine don't change color. It's small quantities of red blood cells in urine. Or macrohematuria is when urine change colors, start to red. It's according to more quantity of red blood cells in urine. Proteinuria, it's present of proteins in urine. It's according to glomerulonephritis or nephritic syndrome. Also differ to low proteinuria and high proteinuria. Leukocytic neutrophils or lymphocytes present in maybe hemoglobinuria and mix. Okay, now we make a short interval, short rest for your cup of tea, nearly 10 minutes. Okay, let's continue our lectures. Examination of kidneys includes different mm, parameters. Palpation. Its examination includes different methods, include the objective method, such as palpation. In the norm, the kidneys, as a rule, are not palpated, except for cases of sharp emaciation and flabby abdominal wall, that more often happens for the woman. A low pole of a right kidney, which in norm is posed lower than left one, mm, can be palpated in asthenic patients. The kidneys becomes palpated in nephroptosis, pathological mobility, and increase of organ in 1.5 or till to 2 times. If kidney is palpated, their form, size, consistence, character of surface, mobility, and presence of morbidity must be determined. Lowered, lowered kidneys is spherical bean-like form with a smooth surface, elastic consistence, painless. Its length is about 12 centimeters. Transfer size is about 6 centimeters in uh, lowered kidney. The increased size one of kidney more often can be in hydronephrosis and tumoral process. In cancer, the surface of kidney is tuberous, consists of increased density, and the mobility is limited. Hydronephrosis increase urinary tract from nephros to and ureter. Especially hydronephrosis may be start when present urine reflux from a different um, stage of hydronephrosis. You can see a small stage, middle, moderate, and severe stage when um, urine reflux present. Hydronephrosis you can see during mixturing cystoretrogram showing bilateral vesical ureteric reflux with ureteric dilatation and dilated cubus calycis on the right. Cubus calycis on the right um, nephros. The synchronous increase of both kidney more often where can be in polycytosis. In this case, kidneys are soft elastic consistent with a raw surface. In patients with hydronephrosis, kidneys are soft consistent with smooth surface. Nephroptosis can be uni and bilateral. 3 degrees of nephroptosis, the first degree 1 to 3, 1 to 4, to lower part of kidneys can be palpated on the height of inspiration during expiration in sleeps abort and cannot be kept by hand. In second degree, full kidney is palpated. It can be kept by hand and its physical properties can be determined. In the third degree of nephroptosis, kidneys freely moves in different direction and even from backbone to opposite side. Percussion. Its typing method. modified Pasternatsky symptoms is used in clinical practice. The doctor stands behind the patient, put his left palm upright on the loin in areas of the 12 ribs and make short, abrupt stroke with increasing forces by the edge of a right palm. The kidneys are not palpated, the mobility of kidneys and ureters points is absent. Pasternatsky symptoms is negative from both sides. Kidneys function test. Zimitsky test. Zimitsky test assesses concentration and excreted functions of kidneys by specific gravity and the amount of excreted urine. The main advantages of this method is that renal function is tested without interfering with normal life of patient. The patient collects his urine at 3 hours interval, and such as resulted 8 portions during 24 hours. He beginning to collect urine from 9 o'clock in the morning after finish at 6 o'clock in the morning the next day. The volume of each portion of urine determined is it's necessary to compare daily diuresis with amount of taken liquid. A normal individual should eliminate about 75 to 80% of taken liquid during day. The daily amount of urine below taken liquids is observed in patient with edema, negative diuresis. Daily amount of urine below taken liquid is negative diuresis. The amount of urine, both total daily volume and volume of each voiding, depend on a number of factors: fluid intake, fluid losses from other routes, fever, environment, temperature, age. Child excreted proportionally more than adult urine. Ingestion of a high proteins diet, which produce more urine, or diuretic drugs. The daily amount of urine over 2000 milliliters, it's polyuria. Polyuria is amount of urine over 2000 milliliters per day. It's for adults patient. It is observed in patients to take much liquid, physiological or in diabetes mellitus, during resolution of edema and after taking diuretic in early stage of chronic pyelonephritis, renal failure. The daily amount of urine below 500 milliliters, it's oliguria for adults. Maybe of patients with kidney diseases, renal insufficiency and unrenal diseases, vomitus, diarrhea, limited intake of liquid after hemorrhage and heart failure, pyrexia. Concentrative function. Fluctuation of specific gravity of urine during the course of the day and its maximum value are determined thus. Normal specific gravity of urine from 1.005 to 1.028 and the difference between small and maximum value cannot be lesser than 10. If renal insufficiency is pronounced, decreased specific gravity becomes permanent. Hypostenuria. Hypostenuria is decrease of specific gravity. If renal function is upset significantly, the specific gravity of urine in all portion is 1.009 to 1.011, which correspond to specific gravity of primary urine of blood plasma, isostenuria. It's isostenuria. In diabetes mellitus, the specific gravity is more than 1.028. Hyperstenuria, it's named, increased specific gravity. Combination of polyuria with low specific gravity of urine and nocturia is specific signs of renal dysfunction. The Reberg test. To determine the functional renal condition, it's possible to examine glomerular filtration, the percentage of reabsorbed water. Renal insufficiency arises in cases where the mass of activity parenchymas is 20% and lower of normal weight. If a substance that is filtrated in glomerulus but is not reabsorbed or liberated in tubules is used for assessment of renal function. The clearance of this substance is actually equal to glomerular filtration. Using this phenomenon, Reberg proposed a test of studying the amount of filtration by endogenic or exogenic creatinine. One of assumes then creatinine content of plasma and glomerular filtrated is the same. It is possible to determine the degree of concentration of glomerular filtrates as it passes through the tubules. Blood is taken from the vein of patient and the fasting stomach and creatinine concentration is determined. Urine is collected during 2 hours. Diuresis is measured throughout and creatinine content is determined. Next, using the formula of amount of glomerular filtration and reabsorption percentage are calculated. In healthy individual, and the amount of glomerular filtration is between 65 to 125 milliliters per minute. The percentage of reabsorbed water is in normal 98 to 99%. As a renal failure develops, glomerular filtration decreases gradually to attain as a 5 milliliters per minute. Tubular reabsorption change less markedly to decrease in case of pronounced insufficiency to 80-60%. The prognostic value of method increased it is used for follow-up studies. Persistent decrease of glomerular filtration to 40-50 milliliters per minute during 19-24 months follow acute glomerulonephritis suggests the conversion of acute process to a chronic disease. To determine the functional renal condition, it's possible to examine concentration of urea, residual nitrogen, creatinine, or in blood. In normal concentration of urea in blood, 3.33 to 8.32 millimole per liter, residual nitrogen 14 to 25 millimole per liter, creatinine 53 to 106 millimole per liter. In renal failure, there's almost increased these parameters. Chemical analysis of urine. Reaction of urine. The kidney an important maintains acid-base equilibrium in the body. The kidney are capable of removing the ion of hydrogen and hydrocarbonate from the blood, and this is mechanism which pH of blood is maintained constant. The mean pH value of urine in healthy subject from normal nutrition is about from 5 to 7 balance. The value of pH is affected by use of medical preparation and characteristic of nutrition. A diet high in meats, eggs, cheese, whole grains, plums, prunes, and cranberries, includes juice and different may decrease pH, producing an acid urine. A diet high in vegetables, citrus fruits, and milk may increase the pH. Down decrease, previous point decrease of pH, and vegetative increase of pH, producing an alkaline urine. Also, the urine pH may be intentionally altered to inhibit bacterial growth or urinary stone development into facilitated in the therapeutic activity of certain medications. And acid urine should be maintained in treatment of urinary tract infection and persistent bacteriuria and in the management of urinary calculin. Conventional as an alkaline urine should be maintained when streptomycin, neomycin, and kanamycin used in treatment of urinary tract infection. Acidity of urine can be increased in diabetes mellitus, renal insufficiency, tuberculosis of kidney, metabolic or respiratory acidosis, pyrexia, starvation. Alkaline pH occur with diarrhea and vomiting, chronic urinary tract infection due to bacterial ammonical fermentation, metallic or respiratory alkalosis. Protein. Testing of urine for protein is based on its coagulation in presence of acid. Normal urine does not practically contain protein. The small quantity of plasma proteins that is present in urine cannot be determined by quantitative test used in practical medicine. The appearance of proteins in urine is oiled proteinuria. It can be of renal or extrarenal origin. Functional renal proteinuria is connected with permeability of membranes in renal filter in presence of strong stimulation, slow blood flow in glomerulus, in intoxication. The urine will contain albumin after a cold bath, excessive exercise, high protein diet, or lordly posture in children, orthostatic. Emotion stress also. In cases with extra renal proteinuria, proteins enter in urine from the urinary and sex ducts. Extra renal proteinuria is not exceed than 1 gram per liter as usual. Organic renal proteinuria cure kidney affections due to increased permeability of glomeruli with underlined by vascular inflammation of structure, disorganization of basal membrane. Glomerular permeability is upset by the molecular mechanism. Low molecular proteins are lost in the first instance. Selective proteinuria. As the process progresses, high molecular proteins are also lost in non-selective proteinuria. Basic membrane of glomeruli. Renal proteinuria occur with glomerulonephritis, preeclampsia, or in pregnant women, on multiple myeloma, amyloidosis, renal abscesses, urinary tract stone. Congestive proteinuria may be indicated of decompensation of heart failure, abdomen cavity tumors. Toxic proteinuria may be after our dosage some medication such as aspirin and analgesics. Neurogenic proteinuria occur with cranial trauma, hemorrhage of brain, myocardial infarction, renal colic. Proteinuria can be moderated when the protein lost is not exceed 1 gram when 20 hours. Average when proteins lost from 1 to 3 gram 20 per 20 to 4 hours, and considerable when proteins lost more than 3 gram per 24 hours. Glucose. Testing in urine for glucose can be done by using reagent strips. The urine and healthy person contain very small quantity of glucose, which cannot be detected by common quantity tests. Glucose in urine, glucosuria, can be both physiological and pathological. In the presence of normal renal function, the glucosuria occurs only in increased concentrated of sugar blood in the blood exceed than 9.9 millimolar per liter. Glucose present if in urine, just if in the blood concentration of glucose increase more than 9.5 millimole per liter. Physiological glucosuria can be observed in persons whose diet with rich carbohydrates, alimentary glucosuria, and following emotional stress, admission of some medicine, caffeine, corticosteroids, less fragments of renal glucosuria associated with distributed resorption of glucose in tubules, in normal amount of sugar in the blood. In renal diabetes, chronic nephrotic syndrome. Pathological glucosuria occur most frequently in diabetes mellitus, less frequently in thyrotoxicosis, and Itzenga-Cushing syndrome or in liver cirrhosis. The presence of ketone bodies in urine is called ketonuria. The urine of healthy person contains very small quantity of ketone bodies, which cannot be detected by common quantity tests. Ketonuria can be detected due to their abnormal fat metabolism. Ketones may be indicated of poorly controlled diabetes, dehydration, starvation, long-standing gastrointestinal disorder, post-operatively, and or excessive ingestion of aspirin. Bilirubin. Normal urine is practically free from bilirubin. Bilirubinuria occurred in hepatic and subhepatic jaundice, at which the concentration of bound bilirubin in the blood increase more than 34 millimole per liter. If concentrate more in the blood, bilirubin increase more than 24 millimole per liter. Bilirubin start determined in urine. Urobilin. Urobilin urobilin is and stercobilin. Excretion of large amount of urobilin in urine is called urobilinuria, which occur in diseases of liver, hemolytic anemia, and enteritis, extensive myocardial infarction, congestive failure, and pyrexia. Microscopic examination of urine sediment. Microscopic examination of urine sediments is made for quantitative and quantitative appraisal of the main urine elements. Epithelium cells of squamous, transitional, and renal epithelium can be revealed. Squamous epithelium enters in urine from external genitalia and urethra. Their diagnostic importance is low. Large amount of squamous epithelium in female can be indicative of bad clearing of external genitalia and some gynecological diseases. Large amount of squamous epithelium in male occur with inflammation of the urethra. Cells of transitional epithelium line the mucus of the urinary tract. The presence of large amount of transitional epithelium in the urine indicates inflammatory process in pelvis or in the bladder, urine bladder. The presence of renal epithelium in urine is a specific sign of acute and chronic affections of kidney and also of fever and toxicosis and infection diseases. Leukocytosis in urine in healthy person is usually neutrophils and the amount of insignificance of to 6-8 in the microscope. Increased quantity of leukocytes in urine, leukocyturia, its name, indicated inflammation of the kidneys and or urinary tract, urethritis, prostatitis, cystitis, and pyelonephritis. Erythrocytes can be altered and unaltered. The urine is healthy person is free from erythrocytes or can have single erythrocytes in preparation. The presence of erythrocytes in urine is called hematuria. Hematuria can be established only in microscopy is called microhematuria, while hematuria revealed in microscopy is called macrohematuria. Physiological microhematuria can be found in physical overstrain of sportsmen. Erythrocyte may be liberated either from the kidney glomerulonephritis tumor or from the urinary tract stone in pelvis blood, urinary bladder, tuberculosis of malignant different variants. In the presence of glomerular hematuria, the urine usually contains much proteins. Protein erythrocytic dissociation hematuria with insignificant proteinuria usually suggests hematuria associated with pathology of urinary tract. Non-glomerular hematuria can have intermittent characters. Cast of proteins or cells formation and tubal origin. They have cylindrical configuration and variable size In normal urine, the casts are absent. Hearing casts are found in acute and chronic glomerulonephritis, nephrotic syndromes, and also physiological transient albuminuria. They can be found in urine or practically healthy people when the pH of urine decreased sharply along with the increase in specific gravity of urine, which is characteristic of dehydration. Presence of granule testing indicated dystrophic process in tubules. Waxy cast is characteristic of chronic diseases of kidney. Non-organized sediment of human consists of salt and precipitate crystals of amorphous substance. Their character depend of colloidal composition of urine, its pH and other properties. Acid urine contains uric acid, urites, and oxalates. Alkaline urine contains amount urate, calcium carbonate, phosphatase. The sediment of diagnostically insignificant phosphate and calcium oxalate crystals occur with hyperthyroidism or malabsorption. Urate crystals occur with serum acid levels. Bacteriological examination of urine very important part of examination of urine. Urine culture remained a standard procedure for diagnostic urinary tract infection. A test of antimicrobial sensitivity of indefinite organism in usually ordered. Never methods help identify the positive specimen more accurately and rapidly. Okay, today we have uh, end of lectures. Please, you can see this lecture in once more, and please you can use this material of these lectures when you prepare to practice classes. Good luck for your studying life in our university.